Now we move to our guest from Sudan, Dr. Awad Mohamed. He's an interventional cardiologist, also chairperson of African Association of Structural and Cardiac Intervention. Dr. Awad will talk to us about something what you already had, aortic dissection during PCI, something new lesson.
Yeah, thank you very much. I'm very grateful and honored to be here with you. I think the idea of this type of having such a course is brilliant, and the way it was executed is second to none. I congratulate the people who are looking after this, and I hope it will grow. It's definitely bound to grow, and this is the way we learn from our complication. And as Dr. Abdullah was saying at the opening ceremony, that if you haven't come across complication, you haven't been doing so much. So this case from Sudan, it was about 2 months ago. This lady of 65 years old, she presented with a good story of angina of effort type of pain for 5 months. Her angina was progressive, the distance was able to walk was getting shorter, her stress test was positive. She's hypertensive, and her hypertension proven stubborn to get under control. Otherwise, there is no other risk factors, and her bioprofile was normal. So we took her to the cath lab. First of all, do you agree that I should have taken her to the cath lab? She was, like, I haven't tried any medical treatment. The angiogram in my country is 100% free for all comers. Her story was convincing, it was genuine. On the right side, you can see mild irregularities in the mid-RCA, but there is no significant occlusive disease, and there's nothing to write home about in the RCA. In the left system, the left main stem is normal, likewise the circumflex, but there is a lesion that you might not be able to see here in the mid-LAD. In this projection, you can see on the right-hand side, the lesion in the LAD just proximal to that small diagonal. It might not see it as significant as on the right side, but you agree that there is a lesion, and that might be the cause of her angina. So I took her for doing that lesion in the mid-LAD. Maybe if you look at the proximal segment of the LAD, it looks diseased, but it's mild disease, although over a long period. So that is a Promus Premier stent. It went fine. I was happy with the result. I just kept a blind eye on the proximal segment of the LAD, and I do not think that what caused what is coming next. So I took my wire out, and I was ready for the final shot. Yeah, it's a proximal dissection. The wire is now out, and the dissection extended. And then you should have seen the state I was in. Nothing has prepared me for this. 20 years of doing this. The patient is very fidgety. Her blood pressure was كجلمود صخر حطه الصيل من علي, plummeting from 160 to 80, and she was in a very bad state. So was I. Now, this is what it looks like. See the contrast, the proximal left main dissection extended into the aorta, and as Dr. Rabih was alluding to, that Dunning and his colleagues in Beaumont Hospital classified this. If the contrast is confined to the cusp, it is called class 1. If it extends less than 40 millimeter into up the aortic root is class 2, and if it is more than 4 centimeter, is class 3, and usually class 3 carries bad prognosis. I think this is just making the 4 centimeter mark. Now, what should I have done in that area? Is looking at the literature, only 2 things that can affect the prognosis significantly: the hemodynamic status of the patient and how fast the operator is. How fast and how bad the patient is. And this is instinctively what I did. My wire is out. So did it go forward or backwards? So I managed to get the wire in the LAD. And if you have seen the circ, can you get this running, please? If you see the circ, there is hematoma extending along the entire length of the circ. So this dissection extended retrogradely to the aortic root, antegradely to the LAD, and down into the circ. I had no wire at that stage in the circ. So I managed to get the wire back, and I parked the stent into the LAD. Now I thought, if I had, after putting this stent into the LAD, I might not get any way back into the circ. So I took a bit of time just to wire the circ. Look at the circ, how the hematoma outside, this is compressing the lumen. So we put that, and then I stented the LAD to the ostium. That is the only thing I could have done. There's no time to think about it. The patient was in a bad state. I was in a bad state. All the stuff was in a bad state. So this is how it ended up. After the stent, we managed to get the flow back into the LAD, and likewise into the circ, albeit not optimal. The ostium of the circ and the rest of the circ was in a bad shape, but the flow in the LAD, dramatic improvement. She started to talk to me again. She was very happy, but she knows that she غيامتها قامت at that stage. She knew she was not doing well, but she was happy that she came back. I left it at that. I took my stuff out, and that is how I left it. You can see the flap at the ostium. The blood pressure was okay, back to 130, 140, and she has no pain, and we got out. We spent 2 days in the CCU. We did not do any imaging, and after 48 hours, I summoned enough courage to take her back to the cath lab because she was clinically perfect. She was praying on standing up, going to the toilet. He has nothing. And after that, this is what I got after 48 hours. So everything was absolutely, the circ hematoma has gone. The LAD flow was brilliant. That was 2 months ago. I just called her yesterday to find out about her, to tell you, and she was in flying colors. She has no symptoms. And now that I saw Rabi has did an aortogram, when I go back, I will do an aortogram on her. But this is how we ended up. And she lived happily after the procedure, and I thank you very much for your attention.
Thank you very much, Dr. Awad. Panelists, please, your input into this.
Thank you so much. Such a great case. I think those are unfortunate situation where, something like this happen. And as you mentioned, being quick and fast is important. Saving the LAD is the biggest thing. And I think once you get the wire there, I agree that you take your time for the circ. Yeah. I wouldn't done it different. I will add imaging at the end just because you already control the situation.
Well,
That's a great case, and it was managed really nice. But I think that from the start, for me, I would have went standing from the left main. The LAD was diseased from the ostium up to the mid segment. It's not wrong. This is my opinion, just an opinion. And the right thing at that time is to stand as happened from left main into LAD and forget about the CX. And usually because the dissection started at the ostial LAD, and when you close the flap, everything will settle. But you didn't send her to surgery?
No,
CT ascending aorta was not done.
no.
That's you're lucky, and she's lucky.
Naif?
Yeah. Thank you very much. Great save. Congratulations. I think this is very tough scenario, especially with intracoronary spiral dissection and in combination with oroto-osteal dissection. But I would avoid pulling the balloon before its full deflation, and I would choose Judkin catheter, especially if the left main is long and there is no osteal problem, there is no CTO or difficulty suspected. I will go with Judkin to avoid such complication. Thank you.
That is, I think, the Achilles to this case was the guide. The guide I used was very aggressive. It's XB35 in an elderly lady. So I think the best thing to do is to avoid aggressive guide.
Quickly.
Just a question. Obviously, first of all, regarding the Judkins guide, there's some debate whether you should go with Judkins in these situations or XB, because the XB will be more stable to not go in and out. The Judkins will go in and out and cause dissection in the left main. So the Judkins can be actually more dangerous. Maybe not a 3.5, maybe a 3.0 would have been better, XB 3.0. My question was, I'm not sure, I mean, obviously the edge of the stent had a dissection, but I think the spiral dissection happened from the guide. I think that's what propagated into the circ and into the left main. All of this was from the guide. I mean, obviously, good. I'm glad she did well and everything healed. That's quite impressive. The thing is, I wouldn't have injected contrast because that would propagate the dissection. I would have been very gentle if I had to puff. And yeah, what Dr. Awad said, we should have done a CT aorta to see if there's any dissection there.
Dr. Fawaz, your comment?
Congratulations, a great save. I always see that long left main is a nidus for dissection, especially if you use either EBU or XP. I will push hard to go with the Judkin, respecting what Dr. Ali say. I think if you cannot wire it, and you are more senior than most of us here, aspiration, especially if the guide already in the false lumen and it's dissection, aspiration to decrease the hematoma, so you're able to wire the true lumen.
Thank you.
Your final talk here, or message for this case?
Yeah, I think we always learn from our mistakes.
Right.
The one thing that we keep saying for the operator to keep calm, I think that is the wrong teaching thing. There's no way you can keep calm in that situation, but we try.
Thank you.
Okay.
Aywa?
Just a comment regarding the use of GL35 or XP or ABU35. I think whatever we use, you are not immune from complication.
Absolutely.
But I keep it as a habit. Before I remove the wire, I have to take a leocaudal or at least a spider view to make sure that the left main is okay before I take my things out.
Very good. Thank you.
Now, thank you, Dr. Awad. Now,